Good morning, everyone. Nice to have all of you with us. Very much appreciated. We are meeting this morning to talk about early childhood development and what is happening in various nations about integrating early childhood development, inclusive early childhood development into policy and service delivery. This is an ECDAN webinar, Early Childhood Development Action Network webinar. So good morning, good afternoon to all of you who have joined us today. Thank you so much for joining us. So we have various guests who will be speaking with us this morning. Which is going to be really interesting, I think, time for all of us to learn about inclusive ECD practices, policies, and some of the things that we might want to implement within our own nation to ensure that young children are being cared for appropriately and that all young children have a chance to be in equitable situations where they are educated, learning, and cared for and nurtured, of course, as well. So thank you so much for being with us. We are going to move ahead and hear from Chiara Servilli, who is with the World Health Organization first. She's with the Department of Mental Health and Substance Use. She's a child neuropsychiatrist by training. She's acting as a technical focal point for UNICEF and World Health Organization Joint Program on Mental Health and Psychosocial Wellbeing and Development of Children and Adolescents. Her work focuses on child-adolescent mental health promotion and protection and providing technical advice to countries. So good morning. Over to Chiara.
Thank you very much for the introduction, and I'm delighted to be here with you today, contributing to this webinar. I had the pleasure of introducing a few key concepts that relate to the topic of the conversation today, stemming from the findings of the WHO UNICEF.
From people all around the world. So thank you so much, everyone. Lots of people who have joined us. And Chiara, can you hear me?
Yes, do you hear me?
I do hear you now.
Good.
Hello, and welcome. Yes, so I have already provided your bio. Your wonderful expertise and knowledge is so appreciated. Thank you for being here with us. And we're going to do a little overview now of the World Health Organization UNICEF Global Report on children with developmental disabilities. Some of the key findings and takeaways, policy gaps and advocacy opportunities, and the lessons learned as well. So thank you so much. I can hear you. Please move forward.
Thank you very much. I'm delighted to be here with you today, contributing to this webinar. I will be introducing some of the key findings or concepts that emerged from the WHO UNICEF Global Report on children with developmental disabilities as it relates to the topic of the conversation today. And yes.
All right. Thank you so much.
I wanted to highlight why, the fact that we are here talking about how to strengthen services and access to early childhood development interventions for children. And this is very much needed if we think, if we reflect on the epidemiology and the current context. We were reminded that 317 million children and adolescents have developmental disabilities. However, countries spend just 2% of their health budget on mental health, which includes in many contexts, the percentage of budget that may relate to conditions that contribute to developmental disabilities. Children with some of the conditions, that we include in the term developmental disabilities, are contributing higher risk of non-communicable conditions and other physical and cognitive and mental health conditions during the life course. And we know that there is a higher likelihood of premature mortality in this population. We also, know about the risk of institutionalization and human rights deprivations and poor quality of care for children with developmental disabilities and their carers. And the workforce competencies and availability is inadequate both in high-income countries and low-middle-income countries. We can reflect on the 0.01 per million per 100,000 population if we think about the speech therapist availability as a global estimate. The global report was developed with the specific intention of mobilizing attention of policymakers and decision makers, and also service planners on this particular topic. And the intention was to provide both a framework for action as well as some key messages and guiding principles that could accelerate changes in countries. Two particular areas of change. One is environments. We want to strengthen enabling environments for children with developmental disabilities, and we want to improve access to responsive healthcare. Looking at the life course perspective, we know that children with developmental disabilities are more likely to experience some of the adversities that from early on in life and across the life course, as we were saying, contributing to both morbidity as well as premature death. And these conditions include exposure to violence, social exclusion, discrimination, poverty, but also lower access to health promotion and care, and poor quality of care, more inappropriate inpatient stays compared to the rest of the pediatric population. We think about transforming systems and promoting better enabling environment for children with developmental disabilities in the context of broader actions. We need to think about what are the distal factors and the proximal factors that contribute to the quality of life and the health and well-being and participation of children with developmental disabilities. And with this key concept in mind, we have embarked in a process towards developing consensus across some few key priority actions that could really help leading towards accelerated actions in countries. The 10 key actions are reflected here, and other speakers will also allude to this. In the next few slides, I would like to reflect on one of these areas that is particularly pertinent to strengthening systems and services. The broader actions address, for instance, strengthening coordination, accountability, monitoring and evaluation, strengthening data research and policy. You will hear more about that. I will deep dive a bit in the next few slides on strengthening services. There is no one a common framework that can be shared, but there are different local realities and contexts and the various heterogeneous needs of a very diverse population of children with developmental disabilities. So what we reflect on is more about what can be guiding principles that can really inform the process of rethinking and strengthening and improving the services and the conditions for children with developmental disabilities. Thinking about services beyond the health sector and embracing also the preschool, the early childhood services, the rehabilitation services in communities, as well as other community-based services. We need to reflect on the fact that intervention need to focus on promoting health capital, functioning and skills, for instance, promoting social skills, prevention of other comorbid conditions, but also, need to have a target towards removing barriers and promoting access to resources. And this type of interventions would include family-based or classrooms-based type of approaches to improve participation, early stimulation, and learning. One of the good practice elements that, it is widely recognized is care and person-centered care approaches, with the recognition of the importance of establishing a partnership with the person and the family and providing knowledge and empowerment for them to make informed choices and take part in the journey towards optimal health and development and well-being. We also know that it's important to act early and to provide access to services according to the needs and as early as the difficulties and the needs emerge. And on this basis, it is important to remind about the concept of making available services that can be transdiagnostic, that may not require in all cases a diagnosis, and that can be made available with the idea of having a strength-based approach and an approach that is informed by a multidisciplinary assessment that recognizes the different areas of strengths and weaknesses and developmental competencies that can be target of intervention, and that can be the basis for some interventions that can actually produce very early in life some cascade effects. If we think about the opportunity of acting early and improving the capacity of caregivers to engage with children, this we know, that if established early on in life can have a cascade effects in terms of enhancing and nurturing environments for children and improving their outcomes. Another core principle of organizing services is called the twin track approach to care, where we recognize that kids are required to have equal access to the mainstream intervention and services and resources also for promotion. But at the same time, they might have more complex and diverse needs that require access to targeted interventions. And there are different examples that I can provide here, but it's just, to remind ourselves about this very important concept and the opportunity of embedding the interventions into a range of opportunities across the different systems. If you think about the WellCare child services, the care pathways, the opportunities in terms of monitoring high-risk children, as well as the school and preschool-based health services. In the Global Report, we have some more in-depth information that I want to just flag to your attention, discussing what could be these opportunities of embedding assessment and care for children with developmental disabilities across services and systems, across the life course, starting early on from the neonatal period and beyond. And of course, the parenting and the parental mental health interventions are part of this approach and a very important element. Every country, including high-income countries, is having a very important unmet needs. And when we look at the situation across countries, we recognize that there are long wait lists to access services. And this is, and there are different factors that contribute to this. I will not delve into this aspect, but I want to highlight that one of the main principles and that we have been looked at in terms of addressing these unmet needs is the principle of organizing step care approaches with deployment of non-specialist providers to be able to work collaboratively with more specialist providers as part of multidisciplinary and collaborative teams that deliver assessment and early interventions. A step approach, is to be flexible, to be informed by choices and preferences and evolving needs of children and their families, and needs to be able to link across different sectors and agencies. One practice that seems to be useful in this regard is the development of individualized service plan informed again by multidisciplinary assessment. This is a way to ensure that there is cross connection and that there is a good communication and less fragmentation across services. Another element that needs to be highlighted is about the importance of not only rethinking and strengthening the organization of services and the delivery of evidence-based care, but also the importance of thinking about the quality of care, the way we align the provision of care to the human rights standards. And also because there is described, across regions, the inappropriate prescribing of medication, particularly in this population, as well as the higher likelihood of these children with developmental disabilities to be exposed to involuntary care and restraint measures. And there are some good practice principles and experiences that can inform strengthening care systems to really address this issue. The last key message for today, from the Global Report for my presentation is about the importance of primary health care. While we recognize that there is a range of services that should be linked up at the community level as part of a broader network of services, we also recognize that the dissatisfaction of care providers and young persons with developmental disabilities often reports the inadequate quality of care received at the primary health care, which is often the opportunity for the first encounter of children with developmental disabilities and their family with the health system. There is indeed a range of interventions that can be delivered also by non-specialists in communities and primary health care. The WHO's MHGAP, which is also reported in the Global Report, provides evidence-based recommendation about the range of interventions that can be streamlined and integrated in the context of primary health care. And this is it for the key messages from the Global Report as relates to strengthening systems. And I'd like to give the word back to Diane and the colleagues, Natalia, for continuation.
Thank you, Chiara. Before you go, could you do something for me? Could you state the full name of the Global Report and just tell people where they can locate it?
Sure. So the Global Report is WHO UNICEF Global Report on Children with Developmental Disabilities. It can be available on both UNICEF and WHO websites. I will report the full title of the report as well as the links in the chat.
Thank you so much. And I should call you Dr. Servilli, so I apologize for this morning. So many of you may wonder who I am. I'm Diane Whitehead. I'm the CEO of Childhood Education International, but we are also the hosts of the Early Childhood Development Task Force, the ECD-TF, which is a network, a global network of individuals, researchers, policymakers, practitioners, parents who are interested in understanding more about early childhood development, inclusion, and everything related to young children with disabilities and developmental delays. So thank you so much, Dr. Servilli. I really appreciate your introduction. We are going to move ahead with Natalia Muffel. Natalia is a program specialist with Disability Section UNICEF HQ and was actively involved in preparation of this latest report, including consultations with external reviewers. She has 20 years of experience working with UNICEF and intensive experience in providing technical support for inclusive health, education, and ECD programs in Cambodia, Myanmar, India, Bhutan, and in building strong partnerships with UN agencies, donors, universities, and international networks. So Natalia, if you are there and could give us a little bit from your point of view of UNICEF around the Global Report. Thank you so much.
Thank you, Diane, and good morning, colleagues. And first of all, I would like to thank many of you who were participating and contributing to this report when it was developed. And first of all, I would like to highlight that the report summarizes the state of the field and my colleague from WHO just ran through with you on key chapters and key messages of the report. And that is why I will be just much more focusing on lessons learned. But quickly, what I wanted to highlight from the very beginning, that we are trying to make sure that based on this data, all of you will take action for change, because children with development delays and their families have long been neglected and must be changed. Report maps out 10 action areas that you can see now in the slide. And Chiara was very quickly showing it, but didn't go into details. And I will not also go into all action areas. I will stop only on 4 of them and will bring really lessons learned and what was documented in the report from the field. First, let me start with deepening the commitment. And the commitment expressed by policymakers can only translate into meaningful changes if accompanied by a substantial increase in institutional commitment, like increase of policies and plans and budgetary commitment. Financial investments need to be oriented towards enhancing services and systems, with particular focus on education and community-based healthcare and improving supports and opportunities at family and community level. And I will give you a good example that was in the report and illustrated this commitment. It's from the Peru, and where they have Cuna Mas program that guides government's approach to early childhood development and establishes indicators for the monitoring and evaluation of results. Cuna Mas is a large-scale ECD program that addresses inequity in ECD in vulnerable populations and focuses on prevention of development delays. And it was study done that identified this program as one of the few ECD-focused home visiting programs operating at scale in low and middle-income countries. The second area that I would like to focus on is strengthen multi-sectoral policy making to address inequities in healthcare and optimize development and health trajectories. Policies, laws, and health financial mechanisms need to be designed or reformed or updated to integrate a rights-based approach and to ensure universal health coverage of children, adolescents, and young people with developmental disabilities. Policy provisions should guarantee equitable, appropriate access to health promotion, prevention, and care. And prevention of placement of children in institutions must be a priority. A pragmatic, collaborative approach is necessary to provide needs-based services with adequate funding for provisions in both government and private sectors. And when we are speaking about cross-sectoral coordination, one good example that were documented in this report is Uganda National ECD Service Delivery Framework that provides a good collaboration, and they have a good ECD technical committee and steering committee that was established as key national governance mechanism for cross-sectoral coordination. The third area is create opportunities for young people with disabilities and their families to participate in advocacy, leadership, policy, program, and monitoring. And it's very important to ensure participation of young children and families in rights-based approach and in development of programs and policies. And we have good examples from South Africa, where it was introduced initiative to address the gaps and challenges in child justice systems for children with developmental disabilities. And the aim of this intervention was to remove the barriers that hinder children and adolescents with developmental disabilities from exercising their right to participate in society. And the last overarching area is to strengthen health information systems, monitoring and programs and services, and research for data-driven decisions and accountability. And research is very important, and knowledge management is extremely important to ensure that we will fill in the gaps, and these gaps will be further filled to optimize policy, programming, and monitoring. And there was done critical trials on early childhood development program for all caregivers. And these trials, for example, it was evaluation of 100 clinical trials, and at 50% of trials, children with development disabilities were excluded. I would like, can we go please to next slide? Of course, the whole report was based on key principles of rights-based approach to promotion of health and inclusion for children with developmental disabilities, based on UNCRC and UNPRPD. I will not stop on these key principles as we are lacking time. Can we go to next slide? I want to stop a little bit on early intervention because we have now done network meeting, which is very much focused on early childhood development. And I can see among participants a lot of people who are early childhood intervention experts. And I would like to emphasize the need for appropriate early intervention to make best use of the proximity of brain development in infancy and early childhood. So early intervention programs are highlighted in multiple areas of the report. And I do think it's important to ensure that early childhood intervention services are provided as early as possible to all children who need them to optimize their development. And what I also want, my last point to highlight very quickly, that at the moment we're in process of finalizing nurturing care for children with development delay and disabilities, thematic brief that should be ready very quickly, soon. And then it will be another guiding material that we're looking forward. Thank you, Diane. I'm hand over for you, and I will be ready to answer any questions if there are.
Thank you so much, Natalia. It's greatly appreciated. And yes, we've kicked off this ECDAN webinar by hearing a little bit about the global landscape, which is so helpful for all of us to put this into context, right? What it means for us and these 10 key action areas, which are so important for all of us to learn and to know about and to try to start to implement. So thank you so much to you both. We are going to move now to a country panel. We have Sri Lanka, Egypt, and Brazil that will be presenting this morning, providing some information to us and some ideas about how they have integrated inclusive ECD into policy and service delivery to support children with developmental disabilities and delays. So they're going to talk about what the primary challenges are in addressing this integration of inclusive ECD. And we know there are different challenges in different nations, actually even in different communities. So we hope we are going to receive some information today that will help us to think about and reflect on what we need to be doing in our own nation or community and how we can really think about the integration of this. It's so important, as we all know, that we attend to young children and their needs very early and ensure that we understand where they are in their trajectory of development. So thank you. So we'll move to the panel. So we are going to introduce Asiri Humalash, and I think I am saying your name correctly, Asiri. Dr. Asiri Humalaj is the National Program Manager for Child Development and Special Needs for the Family Health Bureau, Ministry of Health, Sri Lanka. She has additional qualifications as an educationist and inclusive pedagogy and explores opportunities to combine education, health, and social service sectors to provide sustainable and cost-effective community-based care systems in low-income countries. She's a particularly strong advocate for early childhood inclusion. So welcome. Thank you for joining us. We're looking forward to hearing from you.
Thank you, Dan. Thank you very much for that warm introduction. Okay, hope you all can see my screen. And good morning, good afternoon, and good evening for everybody across the world, and greetings from Sri Lanka. So I will briefly discuss how we have started our inclusive early childhood development program, which we call in the shortened form INCLUDE, and what we have done so far. So to start this, I will briefly tell you a brief description about Sri Lanka for the people who unaware where we are. We are just below the Indian Ocean, and we are a small island, and we have a total population about 22 million in the country, and every year we have a birth cohort about 280,000 children born. And we are a low to middle income country, and these days we had run into an economic crisis as well. But despite all of that, we are very proud of our health services and our mortality indicators, which you can see here, like our neonatal mortality is around 7.2 for 1,000 live births, and even under 5 mortality is around 12.5 for 1,000 live births. But despite that, our focus on children with disabilities was not very high until recently. So understanding the gap of health services for children with disabilities in the year 2020, we started this inclusive early childhood development program, and where we were sort of incorporating, looking at the physical, cognitive, language, and social emotional development of children with disabilities, as well as their typically developing peers in the early childhood development programs we are running across the country. So as mentioned by Chiara at the beginning, we are also focusing on a twin track approach. And while giving universal interventions and services for everybody, and also focusing on specific interventions for children with disabilities. So to explain it a little bit more, so in this INCLUDE program, we are sort of focusing on child development, early childhood development, promotion of all the children, and also developmental screening for all the children. So we are doing developmental screening using 2 care pathways, 3 actually. I have mentioned 2 here. So for the high-risk neonates who are graduating from neonatal ICUs, here who are more prone for developmental disabilities, we are running a specific screening program, assessment of general movements and height assessments, and also all the other children who will be screened and given the developmental promotion advice through our public health system, where we have a public health midwife who is our frontline healthcare worker who goes to each and every house, and they do the developmental promotion and developmental screening. So if we detect a screen positive child, they will be given some additional interventions, targeted and indicated interventions through multidisciplinary training services. And we have a center at a district level, not at the community level, in a hospital, where we initially started with a community pediatrician, speech therapist, and occupational therapist, and a physiotherapist. So they are the people who are providing these additional targeted and indicated services for children with developmental delays and disabilities. So at the national level, so Ministry of Health, Sri Lanka, at the national level, we developed all the care pathways, how we identify and screen these children and where to refer them, and also how to back refer and provide community level services with the support of Sri Lanka WHO. We developed the care pathways, and also we developed management guidelines for common childhood developmental disabilities, including autism spectrum disorder, cerebral palsy, and some of the other common neurodevelopmental disabilities. So this is a very comprehensive management guideline we developed for the country, and this is specially targeting medical teams at the child development intervention centers at the districts. In addition to that, we from the outset, we thought of multi-sectoral collaboration. So we got down all the other services like education, health, Ministry of Women and Children, Ministry of Social Services, and Ministry of Finance. And we developed a common results framework, how we can all work together in collaboratively rather than working in isolation, where we cannot, I mean, we had been working in isolation for a long time, but we didn't see any cumulative results coming out. So we wanted to have a common results framework, and we listed all the services each of our units are providing, and we developed this collaborative attempt from the outset. And another thing that we did was we wanted the engagement and involvement of the community, especially to bring the voice of the parents of children with disabilities. So we invited from the Ministry of Health for parents and also philanthropists who are working in the area of children with disabilities to join with the Ministry of Health to discuss the issues and what are the possible ways where parents can raise their voice, and also where parents and the philanthropists can support the ministry. So we invited them to come with us, and we developed this governance framework. So in this governance framework, from the Ministry of Health, we established a national steering committee for childhood developmental disabilities. This is chaired by our Director General of Health Services. And under that, we have two subcommittees chaired by our Deputy Director General of Health Services. And that is, one is technical subcommittee. This is where for all the clinical medical people who are working with children with disabilities to come together and discuss the needs and the areas to be improved. And the other subcommittee is this PPI, the Parent and Public Involvement and Engagement Subcommittee, where we got all these mothers and fathers and philanthropists who said we want to come and support into the ministry. We officially gave them letters, and we have a platform once in 4 months. They come and meet our Deputy Director General of Health Services, and they raise their concerns. So we have seen this is a very powerful, this had a very powerful effect, because when parents talk, we realized even our health administrators understood the importance of focusing and prioritizing the issues of children with disabilities. So nowadays, these parents are advocating and pushing us to develop a disability identity card, and also they are pushing us to have regulatory mechanisms for these private sector institutions which are providing a lot of interventions which are not evidence-based. So now we are trying to regulate that. So this National Steering Committee again is reporting to another higher level policy mechanism, which is chaired by the Secretaries of Ministry of Health, as well as Secretaries of Ministry of Women's and Children's Affairs. So we have this structure, and this is now operating, and we are getting some results from that as well. So at the grassroots level, now that those things are the national level attempts we made. So at the grassroots level, we sort of provide interventions using 3 models. So we have home-based services provided by our frontline health worker, public health midwife, and divisional clinic-based and regional clinic-based services. So this is what you are seeing is a regional sort of a hospital-based clinic. Once the public health midwives or anybody identify a screen-positive child, they will be referred to this divisional center. So we have utilized some of the, not the very big hospitals, but underutilized hospitals to have a clinic, which is not very resource intensive. And these small clinics are converted into multidisciplinary intervention centers. So we have all these speech, occupational and physiotherapists and the nursing officers and medical officers working together and also providing individualized support. And here we give like, this is not a walk-in clinic. Once the screen positive children are identified, we give an appointment for the family to come and visit, because we understand that these children with difficulties, the mothers and fathers cannot waste their time in the clinic. So they get an appointment and they get individualized attention and care. So what we are promoting at these clinics are parent-mediated, home-based, play-based early intervention. So our target is to identify kids as early as possible. So these clinics have already established in Colombo district, and we have established in Kandy district, that is central part of the country. This is an example of the Kandy district clinic, and also in eastern part of the country, Batticlaw, and also in Kaluthara, that again in a urban setting. And the main target is to sort of counsel parents, train them how to play with the child and how to provide this early intervention at home. Because we are also a resource poor country, so we can't ask the parents to come all the time to these clinics. And also we are sort of providing outreach clinics as well for parents who cannot come. So across the country, so far, we had been able to establish 5 centers. We have 26 districts, but out of these 26 districts, at the moment, we have established clinics only in 5 centers. So that is what we have done and for these children. And however, so when we wanted to scale up this program, which had been running very beautifully, we are facing a lot of bottlenecks. Mainly the human resource, trained human resource is our biggest bottleneck, as I think Chiara very nicely showed in the first slide, like the ratio of trained therapists for the number of children. So we are also having the same issues. And also, as a country, we are facing an economic crisis, and economic crisis again has resulted in out-migration of a lot of our trained people. So most of our trained consultants, doctors, and therapists are migrating out of the country, which again making it very difficult for us. And also another very huge bottleneck is stigma and discrimination associated with children with disabilities. So as solution, we are thinking of different ways how we can task shift, how we can go for tiered service models, and how we can use digital solutions. So now we are looking at tiered service delivery. So tier 1 at our primary healthcare, where we are doing a lot of screening, and we are trying to introduce autism-specific screening also. And tier 2, we are trying to utilize our medical officers and nursing officers to provide some of the interventions, and we are trying to incorporate WHO CST intervention and FAST plus intervention for autism and early intervention. And our tier 3 is our clinical specialists using providing indicated services. And also we are trying to see how we can utilize non-specialized health workers, field officers in other ministries, preschool, primary school teachers, and peers and mother support groups for provide some mother services. As digital solutions, we are looking at telehealth, and we are using a lot of social media awareness campaigns for to address social stigma and discrimination. And we are trying to see how we can incorporate video gaming to change the way little children look at disability. And also we are trying to get down WHO CSTE version, so we can use that as well. And also we are doing Namaste, this research, 5 years research on autism in Sri Lanka, which we have got a lot of support from there. So this is again Dawn's slide, and I'm reflecting on what we have done over the years, and I can see we have done most of these things, and we have a huge way to go. We have so much to improve, and also we have not addressed about these certain pillars of these 10 actions. So I think, yeah, so far I think we can be happy, but again, there's a long way to go. Thank you very much.
Thank you so much, Dr. Hugh Malage. Am I saying that correctly?
Heva Malage, yes.
Hugh Malage, yes. I'll let you say it. Thank you so much. I appreciate it, and forgive me. So thank you for providing information and wonderful, wonderful videos and explanations about what is happening in Sri Lanka and how you are moving this all forward. I really appreciate that. Thank you. So next we are going to move to Dr. Iman Garber. and Addiction Treatment, Ministry of Health. She is the coordinator of the UNICEF and WHO where is my joint program on mental health and psychosocial well-being for the development of child and adolescents in Egypt. So, Dr. Iman Garba, are you there?
Yeah, hello. Hi.
Hello. So nice to
Hiya.
see you. Thank you for being with us.
Thank you. Thank you so much. Do you see my presentation?
Yes, we can see it. Thank
Okay.
you.
Thank you. This is my office actually. And uh, okay, I will try to give you an overview through the years. My department is started in 2011. At that moment, there was no services for autism in public hospitals, and we was having a vision at that moment, starting to put a vision that we need to have a child and adolescent mental health services with quality and without stigma all over the Egypt. And at that moment, we was just 6. Now we are 15 team all over the country trying to provide services for child and adolescent mental health. But with autism, we started to put the vision in 2012 when we have the support from UK and from Embassy of Slovenia, who have these meetings to start to think what we should do to have services for autism. And we were thinking that first we need to have our national program for autism, and we should build the capacity of the staff, because at that moment, most of our staff wouldn't have enough training in this field. So we started to do our daycare services in Abbasiyah in Cairo, and another one in north in Ma'mura, Asyut in the south, and Port Said in the east. And started to do these small units just to have a good training for our staff. Through the years, we was trying to convince the minister, the prime minister, that we need to have early intervention and early detection for autism. We do a lot of awareness campaign every year with Autism Speak Light Up Blue and with the Egyptian Society of Autism. We trying to convince them to start the early detection. But at that moment, it was hard to convince them because we don't have enough services. When you are telling them, please go for screening for autism, and I just have 4 small centers servicing less than 50 child. They told me, what's next? What if we know that the child have a problem? What we will do next? And do a lot of national and intersector meetings trying to have, but still the problem that we don't have enough services and the number of specialized personnel is very limited. Since I met Andy in 2016 and start to know more about caregiver skills training, and WHO start to support us in this program, what I can see from our journey that caregiver skills training program was a catalyst to make a commitment for our government to children with autism, and to start to think that we can do a real plan for them for early detection and early intervention. As maybe most of you know, that this is what the roadmap that we put in 2016, and at 2020, just before the COVID, we have our master trainer just to start to implement. Since 2012 till 2020, we failed to convince our government to have a commitment for early detection, early intervention, and real inclusion of service, of real development, early developments of children in their package. But in 2020, once we had the training and the master training and started to think about what we should do next, and we practice with the families and get their feedback about how much this is important, we do the COVID, when they have the COVID, start the online adaptation, which was very beneficial for us, because we have some challenges with home visits, because this is not culturally accepted in our country. So when COVID come, the solutions that have been provided by online training was great for us and give us more information. This is just 2 years, just in less than 2 years. In 2022, our Prime Minister was having the first commitment from our government that we are going to plan to have the early detection, early intervention initiative for children with autism, and to make it one of the package of services in primary health care services. And this just because we have a very realistic plan. You know, we have the translation of MChat. This is one of the screening tool, which is very easy, that can be done by non-specialized personnel. What we assume that we can do it is to train the people in the primary health care to have this screening parallel to the vaccination. In Egypt, we have a good program for vaccinations with coverage rate around 95% in the primary healthcare units. So what we thought, if we do this parallel to this and ask the mothers for some information, will be helpful. And what we do next, we have this screening programming through the mental health platform. So even if the people wouldn't like to do it inside the primary healthcare, they just can do it by themselves through the internet. And actually, I think this is a good solution. However, it's not suitable for everyone. We cannot depend on the online because in Egypt, we have many of the population are not, they are illiterate, they are not internet friendly. So we cannot think to depend on this only matter. Do that, we choose some people inside the primary healthcare and start to train them on MChat and do it in electronic. This is our referral pathway. This is what make our minister to convince them that we can do this. We said that we will have a screening at 18 months. If it's delayed, we just give the mother some tips. And if it's not delayed at 24 months, we will have another screening. If it's not delayed, it's okay. If it's delayed, we'll go CST. Till this moment, no professional, no one specialized mental health have seen the child. They can be done by non-special personnel. And after we train the facilitator, they can do the CST. If the patient improved, it's okay. If it's not improved, here will be referred to specialists with the psychologist, psychiatrist, pediatrician, and go for the process of diagnosis. If it's not autistic, it will be referred. If it's autistic, we, through the years, developed our daycare centers. And because of the local, we cannot offer APA or daycare centers for all the children. So we do 3 levels of intervention. And we said that the selection will depend first on compliance on CST. If you are good compliance, you will have more chance to join the daycare center and you will take full hours, more than 25 hours per week APA in our daycare center. If they are not, or if they have another solutions, like mothers maybe are well educated, they would like to learn to work with their children, or sometimes they can afford to have a therapist for their children, so they can go for the weekly plan or monthly plan that we put the plan and follow up with them to be sure that the child is going on. Because of this, we work on the small units that we do it in 2012 and started to make it a good place for autism with there will be outpatient clinics with the diagnostic tool, very well trained staff. And also there is a daycare center that we will do it for just 30% of the according to the statistics, we can offer this just for 1/3 of the cases that we will have it after the screening. But it's a good start. Actually, in the opening of this center, our Minister of Health of Population come in a companion with Her Excellency Minister of Social Solidarity, because we believe it's not just about health, it's a lot of and multi-sectorial collaboration. So social service, especially at the age, we hope that we have the children in these centers at 2 years. Before, we are receiving the children coming to our centers at 6 years when they are going to the school, and they finally discover that their children are delayed. But now we are having the children at 2 years, and we think that a lot of other services should be managed. And also we think that a lot of work should be done with Ministry of Education. Because of this, we are continuing advocacy on both on community, because this was our International Autism Day, and we're lighting up our Grand Museum, and also the professional perspective. So we have the privilege to have the Pan-African Congress of Autism in collaboration with Speaks April 2024. All of this just to continue our plan to have a good services, not just from health sector, but from other sectors. We believe, the train to move, the first car should move. Ministry of Health is just the first car, it's not the train. We should move that to make others move and to make the package of services are suitable for those children. And thank you. This is some challenges we are facing. Of course, on the ground, there is a lot of logistics challenges, but we are trying to overcome. I think the capacity of the professional staff and supervision is something need a lot of learning and continuous learning. And of course, update our, we have the guideline, we developed our national guideline, but I think more and more developments needed to be enough and to be with high quality. And thank you so much.
Thank you so much, Dr. Gaber. Really appreciate the presentation. Really some wonderful information coming forward to us today about how governments are dealing with some of these really big challenges, right? How do you put all these parts and pieces into play to create that holistic system that we know we need in order to support young children, to do the early identification, the early intervention, and to get everyone who's involved in that child's life at the same place, right, at that moment. So thank you so much. Very, very much appreciated. So we've heard from sort of government perspectives, how to set up different parts of these systems, hearing from Sri Lanka and from Egypt. We'd like to move now to a little bit of a sort of thinking about parent sort of service providers. Why do these policies really, matter to us, and what challenges are being faced from that parent side? So we're going to hear a little bit from Ana Lucio Rago from Brazil. Good day. She is a dedicated physiotherapist with a postgraduate degree in psychoeducation and over 25 years of experience working with children with disabilities, their families, and educators. As Perkins representative for Brazil, she supports the inclusion and education of young children with disabilities, collaborating with local governments across Brazil to ensure no child is left behind. And we've heard of Perkins, sometimes called Perkins School for the Blind, and I think you're going to explain to us as well how that name fits into actually a much more holistic view and what Perkins is working on today. Welcome.
Thank you, Diane. Thank you for your question. Hello, everyone. So, for those who do not know us, although Perkins was founded as a school almost 200 years ago, today we are a US-based international organization with global impact, supporting children with all disabilities to access quality learning. In Brazil, we work in inclusive schools and early childhood education programs supporting the inclusion of young children and align with the country's public policies on inclusion. So the law of inclusion in Brazil mandates that every child must attend the regular education system and receive the necessary support to progress in their development and learning. Well, we know that public policies are crucial to bring about change. So public policies are essential to guarantee the rights to health and education to children. But as highlighted in the Global Report, children with developmental disabilities often face low expectations and exclusion from school. Well, in my experience working with early childhood centers, I see that in addition to public policies, service providers, families, and caregivers need practical knowledge and skills to address the needs of children with disabilities. This is essential to create an environment that promotes learning to all children, including those with disabilities and those at risk of developmental delays. Well, governments and programs have shared with me about many issues they have in implementing public policies. Teachers often say, since they don't have the experience working with children with disabilities, they don't have the skills they need to support them. We do know that governments make efforts to give training and support inclusion, but they are not enough to guarantee the efficient inclusion in all centers. We learned through our experience that the support to service providers in a very practical way, through training, mentoring, and hands-on approach, can really help to improve the quality of education. So let me share an example with you. There is an early education center that we are working with in Macapá called Creche Tia Chiquinha. Macapá is in the Amazon region, a remote area that you can access only by plane or boat. At this center, I could meet young children with disabilities included in the program, but without good opportunities for learning. Excuse me. I met this girl with multiple disabilities using a wheelchair, while the other children would enjoy a coloring activity. She could not participate because there was no adaptation for her. Teachers had no skills to support her active participation, and also they didn't have enough resources like specific materials or specialized teachers they could ask for guidance. The partnership we did with the government of Macapá was critical to our support success. Together, we assessed and addressed the needs of the early childhood center. For instance, I gave training in specific topics to the educators and monitored one-on-one progress, supporting teachers and children with the hands-on approach. This made teachers and administrators feel more confident and get the skills they needed to teach children with disabilities, like this little girl that now has more adequate opportunities for participation and learning. So for the team, our support gave them the ability to change pedagogical strategies. Also, they are now able to early detect different conditions like low vision, which they could not do before. Besides, together with the government, we coordinated with health services like speech therapies to provide assessment for the children. As we all know, the articulation between health and education services is critical, and developing a collaborative work between these two sectors will further better opportunities for development and learning. Another action we took was to train families with the information and skills they need to help their children learn. Our team in Brazil includes a family coordinator who is a parent of children with disabilities and speak to both parents and the school team from her perspective as a mother. Well, in conclusion, from my experience, the big challenge facing parents, service providers, is the lack of practical support. I see we do have good policies, but services need this hands-on support to put policies into practice, which is fundamental to the children to access programs that really support their development so every child can learn. So thank you, Diane, for the opportunity. I hope I answered your question. I could share a lot of examples, but we have not too much time, right?
Sadly, we are limited by time today, but thank you so much, Anna. These examples are so helpful to us all. And of course, we know that parents and caregivers are central, right, to this. So really, really, really appreciate your input and thank you. All right, so now we are going to move to a call to action. That is so important for us as we think about this new global report. So we are going to move to Pamela Dixon, who is the Senior Director of Clinical Services and Inclusion at Autism Speaks. Pamela's portfolio includes serving as the technical lead with a caregiver skills training program, the Autism Speaks WHO collaboration that provides training to caregivers of children with developmental delay disorders. She also manages a global advocate network, and I'm sure there are many other things that you do, Pamela. So thank you for being with us, and move ahead with our call to action.
Thank you, Diane, and thank you to all of our speakers today. I've really enjoyed hearing all of the examples of what is happening at a country level. As our representatives from WHO and UNICEF shared, these 10 priority action areas that you see on the screen are described in the report as a way to really accelerate changes in policies and care systems for health, well-being, and participation for children with disabilities. And so our presenters have kindly provided us with descriptions of how these action areas have been employed in integrating ECD programming into policy and services in their countries. And so my goal is to kind of highlight some of the key action areas that our presenters described. So they covered several different areas, but there were a few key action areas that emerged from their presentations. So I will start with talking about strengthening services for inclusive and people-centered evidence-based care. So our presenters shared several examples of how they used this action area in promoting programming. So in Egypt, we heard that there was an early program or focus on early detection and screening that has developed into national policy and developing autism centers and a national strategy. In Sri Lanka, we heard about the intentional use of a twin track approach to make sure that children with disabilities have their specific needs met, but are also being mainstreamed into activities, and that the environment is changing to meet their needs. We heard from Brazil about the Macapá region project and the use of a needs assessment in order to focus on the specific capacity development needs in that region. And we also heard in all sites about the use of tiered models for providing services. So using specialists and non-specialists to and using local centers and hospitals to provide services for families before referral to more specialized regional centers. Next, I want to highlight that the sites that spoke today really focused also on strengthening multi-sectoral policy making to address inequities across areas such as health, education, and social protection. So we heard in Sri Lanka about developing a common results framework, and Egypt about national recommendations and policies. And then finally, if we look at the center of this slide, we have there were lots of activities that focused on promoting participation and informing and empowering caregivers. So we heard from Sri Lanka about inviting parents to be part of a national steering committee. In Egypt, there were online surveys for parents to be able to do screening on their own. And from Brazil, we heard about parent training and support being a really important part of their activities. And we also know that the caregiver skills training package is being implemented in all 3 countries. And this is a really important tool that the WHO has developed that can be used because it's specifically developed to support caregivers of children with developmental disabilities. So, you know, for those who are participating in the audience, we know that you are actively involved with trying to solve development problems, and they can seem kind of insurmountable at times, but it's really helpful to have a framework like this one that's presented in a global report because it gives these specific strategies. And so I think it's important to note that even though there are these strategies are presented in this format, it's intended for them to be modified. And we've heard about examples of them being adapted to meet cultural context, to be able to meet specific needs of children in their communities. But I think our colleagues also provided excellent examples of some common threads. And so I want to just highlight some of those common threads. First was advocacy. We heard deep commitment from those who spoke about working towards change. And so we heard examples of providers and professionals and people with developmental disabilities and parents and policymakers making the case for these changes. And second, we heard a lot about multi-sectoral collaboration. We have many systems involved in policy and service changes that were discussed today. So we heard examples, of course, of country governments, but also UN agencies and professional organizations, as well as donors, you know, working collaboratively towards change. And finally, we heard about how these changes happened over time. And I think it's important to note that small incremental changes matter. And so for those who are listening and doing this work that feels like small incremental change, I think that's really important because it does contribute to larger outcomes. So, I've certainly learned from the journeys we've heard today and let us just keep moving forward to move children with developmental disabilities from the margins to the mainstream. So thank you, Diane. Back to you.
Thank you so much, Pamela. Really appreciate it. Thank you so much for sort of moving us through what we've been learning about today, and then thinking about it in the context of these 10 action areas for this new global report that we're speaking about today. Thank you very much. So we are going to move now to Q&A. And if you have questions, you can certainly put them in the chat. We have somebody who's going to be taking a look at that and putting the questions forward, I think, to me.
Hi, everybody. I'm Brett Weissel with ECDAN. And thanks to Tiara, I know she's responded to several questions, but I see a great one here about scaling. And the question comes from Mark. Mark Aguirre, one of the biggest challenges is scaling programs like this. I would be interested to learn more about programs that are going to scale. And I think it's a great question to start off with, and was hoping perhaps our representatives from Sri Lanka and Egypt could share a little bit about scaling and challenges that they face in scaling programs that you've shared today.
Can I go answer?
Please, Asiri, go.
Yeah. So the screening, of course, what we have done is we have introduced this early screening program using the CDC checklist we have adapted to local languages, and we have incorporated it into immunization points in the early childhood development program. So in Sri Lanka, we have immunization coverage almost 100%. So our children come at 2 months, 4, 6, 9, 12, 18, and 18 months, and 36 months, and 60 months for immunizations. So we incorporated the developmental screening into these immunization points. So when they come to the immunization clinics, our field workers can screen them for developmental delays. So mostly those are like simple questions asking from parents whether they follow certain milestones, and even if one is not happening, we are referring them because our main target is to identify them early as possible. So that's why we have 5 screening points in the first year, 2 screening points in the second year, and then subsequently 1 screening point. So up to 5 years, we have 10 screening points at the moment. This is not a very robust screening, but a crude screening, but it gives us, it gets the people, and because early intervention is harmless, we thought it would be better rather than without doing any screening. So that's what we are doing.
Thank you for that. And over to you, Dr. Gaber, do you have thoughts?
For scaling up, actually, to start this process, we started to find the resources, the available resources we have, because to start the screening or the training, what are the available human resources we have, and what the time we have, and what is the, all the financial resources for training and for spreading the services. So what we have to start is to discuss what we have, and to see the time and the number of personnel in, for example, primary health care. They can give us how many hours per day to do the screening, and if we will do the CST in the primary health care, how many people will be available for how many hours, to see if will be applicable to start with these huge numbers, or we should think for 2 years we started very limited because we don't have the real buy-in. But once we have small successes, the government and the primary health care started to convince that yes, we can give you staff and people to work, and we are just added 1 step on already well-established system, because to start a system from the scratch, will need a huge efforts. So we just add 1 step on a very well-established system, that is the vaccination program. And for the CST, we started small units. Now we are starting to see what we can do for the supervision and the training, and we do it in phases. We will start in 1 governorate, then we will go for another 2 governorates, and then go for 3, and then for 5 years we will cover all the country. We cannot do it just at once, because to scale up and to have the human resources that are well trained need time. I hope I give you your answer.
That's very helpful, and I'm sure it's very relevant to everybody on this at this webinar, because scaling remains challenging in any context.
Yeah.
Any other panelists have a thought on scaling before we move on to the next question? Chiara, do you want to
Yes,
chime in on scaling?
yes, just to share, given that Dr. Iman has mentioned the CSC experience in Egypt, I just wanted to mention that other countries are currently adopting the approach more, as part of national care systems. Some are more advanced in the process, some others are at the beginning of the stage. I just wanted to mention, as Brazil is represented here, but not the government, and the Ministry of Health of Brazil has recently started a process to actually adopt the approach as part of the broader vision around strengthening services. So we look forward to more learning and experience coming from that process.
Thank you. And there's another question here that I think is going to be very relevant to all the panelists as well as everybody on the webinar, and that's around inclusivity. And this question comes from Shivanjini. And the question is, how have you promoted inclusivity amongst mainstreaming schools? Dr. Gaber, do you want to start with this one? Promoting inclusivity amongst mainstream schools.
Okay. Actually, we started in early age. We started in just before the school. Our plan is to have these centers in from 2 to 4 years before the school, to give the children the chance to go for inclusion and to have more basic skills for them to if the children, of course not all of the children will go for school, but at least we open the channel for them to go and to have the system for inclusion. In Egypt, we have a law for inclusion. However, we know that in the real environments need a lot of work to be realistic. And till this moment, we still have some struggles in this. But our plan is just the age before this. And we are trying, we have the daycare just 6 hours or 5 hours per day. Other time he's with families, goes doing a lot of activity with the family, trying to support the mothers to do this. And we are still discussing with the Ministry of Social Solidarity about the package of service they can offer for the mothers to support them more and to make them more included.
And Dr. Humalaj, do you want to share a little bit on promoting inclusivity?
Yes, so it is actually we are struggling. So in our education ministry, they have said that there's inclusive education in Sri Lanka, but actually it is not inclusion. It is not happening. So it needs a very huge attitudinal change, and the social stigma and discrimination, we found it very hard to understand other parents, especially in the education system, in school system, that it's important to have these kids, and also it promotes learning with all the kids. They are the best ways to learn with all the kids. So to do this, we are finding it very difficult, and we are trying hard, like we are trying from two ways. One way is through our antenatal programs and early childhood programs. We are trying to discuss about developmental disabilities and increase the awareness among parents. And also we are running social media campaigns, and we are running media advertisements, and we are bringing out successful sort of like kids who perform well with a disability and promote these characters in the community. Likewise, we are trying to create a social discourse. And also at the same time, Education Ministry of Sri Lanka was very successful recently in passing out a circular saying that every school has to give a proportion of admissions to children with disabilities. And also examination departments are also accommodating some of their assessment systems to provide facilities and additional support for children with disabilities. So efforts are happening, but it's very, very slow. And also one main obstacle I see as that hampers inclusion is the education, the way we educate our kids in this part of the world. We are still using didactic education methods where the whole class is there and one teacher is training in front of everybody. There are no individualized education plans in the system, and even no universal design of learning. So those approaches are not yet in the country. So that's why it is very hard for us to promote inclusion. So we are struggling because health system is moving ahead, and if the education system is not moving ahead in parallel, there will be a gap because health will not be the system which provides care for these children throughout their lives. So once they start schooling, school system has to take over. So that's why we wanted to get them into the same understanding and push the education system also. So we are still doing it. Thank you.
Natalia, do you have thoughts to share?
Yes, I was about to start to speak. First, what I want to highlight that it's important to start changing the system instead of trying to change children. Then the system is becoming much more inclusive and oriented to include children. And then it's two stages. It's also about how community and parents are working together, because it's first to ensure that children are not fully excluded, because in some cultures, in some countries, children can be really kind of locked in their rooms at home. Then it's about all development of parenting. And what I also wanted to highlight, to add to Sri Lanka experience, it's about transition. It's about early childhood education and then transition to school. We cannot start just with school. Question was much more about inclusive school, but it's starting much more early. And then in school system, it's multiple layers of change, because it's related to changes of policy, it changes of curriculum, and changes of standards, and changes of learning assessment, because then it's also how national education assessment is done inclusive. So it's multiple layers, and for sure it takes time. But then the whole question is how Ministry of Education can think thoroughly and to organize the whole system with all these multiple dots bringing together. Thank you.
Thank you, Natalia. And before we hand it off to Diane to close out, Ana Lucia, I don't want to put you on the spot, but I just wanted to see if you have any final thoughts, particularly from the community perspective around inclusivity.
Yeah, thank you. Well, in Brazil, as I said, the children are in regular school since the very first beginning. So they are included in regular childhood centers. And I think this is very important because they have this, all children have the experience of diversity since the very first beginning. And also they have the support of the rehabilitation system. They have in another service, in the health service, they have the therapies that they need to get the abilities to have more conditions to participate. So, and to develop. So what I think, as I said before, is that this articulation between the health service and the educational service is very critical. So both services have to support each other. And as I said, also, the government of Brazil is making a lot of efforts to support the inclusion since the law of the inclusion, but the demand is too big. So I also think that the partnership with the civil society is fundamental to face the challenges that the inclusion brings to us. As all we said here, inclusion brings a lot of change, a lot of challenges. A lot of challenges. So I think that this partnership between the government and the civil society will maybe accelerate the efforts we can do together to face the challenges of inclusion.
Thank you. I'm going to go over to you, Diane, to close this out.
All right, thank you so much. Well, this has been extremely insightful and helpful. I really do hope it was helpful to you. There will be a recording available of this session. I hope that some of you go back and take a look at this. We have been talking about the global report on children with developmental disabilities today, and looking at that in the context of various countries and what they are doing. We had examples from Sri Lanka and Egypt, and also from Brazil, from sort of the parent and perspective, how we can work in community. What will your nation do as your call to action? And that's what sort of interests me as moving this forward to next steps. There are 10 wonderful action areas in this global report. Take a look at that. Is it something you can do on the national level? Is it something that you need to do embed in communities? There is so much rich information that we can extract from the global report and from looking at these 10 action areas. Use them to assess where you are at in your development of these systems and processes. We know that the Sustainable Development Goals, number 17, calls us to build bridges, to build partnerships. We have to work across sectors, and we've heard that talked about several times over and over again within the presentation today, and I'm sure you will hear about it in your regular work life as you work on some of these issues. At Childhood Education International, we talk a lot about communication, collaboration, consensus building. How do we move to collective action? How do we bring this forward in our advocacy efforts and make real systems speak to each other and those processes that can really support these young children? Very, very important. So I'd like to just say thank you. Thank you to ECDAN for holding this webinar. Thank you to all of our panelists, and thank you to you, all the participants who took time to be with us today. And we wish you well as you move forward and build those systems that are going to support all young children. Thank you so much.